Hey everyone, welcome back to NSG 3046 Adult Medical Surgical 2. I'm Heather Murphy, and today we're diving into a topic that honestly every nurse needs to have down cold: stroke. Now, if you caught our last episode on increased intracranial pressure and brain injuries, you'll remember we talked a lot about how the brain is super sensitive to changes in blood flow and pressure. Well, stroke is kind of the ultimate example of what happens when that blood flow gets interrupted. So let's break it down. The brain needs a constant supply of oxygen and glucose, no exceptions. If that supply gets cut off, even for a few minutes, neurons start dying. That's what a stroke is, an interruption in blood flow, either from a blockage, which we call ischemia, or from bleeding, which is a hemorrhage. Ischemic strokes are way more common, but both are emergencies. The main highways for blood to the brain are the internal carotid arteries up front and the vertebral arteries in the back. If you think about it, anything that messes with blood pressure, cardiac output, or even how thick the blood is, like say dehydration or polycythemia, can affect how well the brain gets perfused. I'll never forget this one patient from my early days on the neuro floor. She was chatting with her husband one minute, and the next she had sudden right-sided weakness, and her speech it was like she was trying to talk underwater. Classic signs. We rushed her for a CT, and sure enough, she was having a stroke. It really drove home how fast things can change and how important it is to recognize those symptoms right away. And as we talked about before with brain injuries, time is brain. Every minute counts. So understanding what's happening during a stroke, whether it's a clot blocking an artery or a vessel bursting and bleeding into the brain, sets the stage for everything else we do as nurses. Now, let's talk about why strokes happen in the first place. Some risk factors, unfortunately, we can't do much about, like age, gender, race, and family history. The older you get, the higher the risk, and there's a bit of a gender difference too, with men having a higher risk at younger ages, but women catching up later on. But here's the good news. There are a bunch of risk factors we can actually do something about. Hypertension is the big one. Seriously, if you remember anything from this episode, let it be that controlling blood pressure is the single most important thing we can do to prevent stroke. High cholesterol, smoking, drinking too much, obesity, not moving enough, poor diet, even certain heart conditions and drug use, all of these play a role. When we talk about types of stroke, ischemic strokes are the most common. These include TIAs, or transient ischemic attacks, which are like mini strokes. Symptoms last less than an hour and go away, but they're a huge red flag. About a third of people who have a TIA will go on to have a full-blown stroke, so we can't ignore them. Ischemic strokes can be thrombotic, where a clot forms right in the brain's blood vessels, or embolic, where a clot travels from somewhere else, like the heart, and gets stuck in a brain artery. Then there are hemorrhagic strokes, which are less common, but often more deadly. These can be intracerebral, where a vessel inside the brain bursts, or subarachnoid, where bleeding happens in the space around the brain, often from an aneurysm. So how do we as nurses help patients manage those modifiable risk factors? I always think of Mr. Johnson, a 62-year-old who came in with a stroke and turns out had been skipping his blood pressure meds and eating fast food most days. It's not about shaming patients. It's about meeting them, where they are and helping them set realistic goals. Maybe it's checking their BP at home. Maybe it's swapping out one unhealthy meal a day, or just getting out for a walk. Small changes add up. And, sometimes it's just about having that conversation. Hey, did you know that controlling your blood pressure could literally save your brain? It's simple, but it can make a huge difference. All right, so let's say you've got a patient with sudden weakness, slurred speech, maybe some facial droop. What's next? First, we need to figure out what kind of stroke they're having, because treatment is totally different for ischemic versus hemorrhagic strokes. That's where diagnostic tools come in. MRI and non-contrast CT are the big ones. CT is usually first because it's fast and can quickly show if there's bleeding. If it's an ischemic stroke and we catch it early, like within 3 to 4.5 hours from when symptoms started, patients might be eligible for TPA, a clot busting drug. Timing is everything here. For hemorrhagic strokes, TPA is a no-go. Instead, we might be looking at surgery to stop the bleeding or fix an aneurysm, plus managing blood pressure and preventing complications like vasospasm or seizures. Nursing management is huge in both cases. In the acute phase, we're watching airway, breathing, circulation, and keeping a close eye for any changes in neurostatus. We're also thinking ahead to rehab, helping patients regain as much independence as possible. I remember working with a patient who had a severe left-sided stroke. It took a whole team, PT, OT, speech, dietitian, social work, you name it. But over time, he went from being completely dependent to walking with a cane and even cooking simple meals again. That's the power of multidisciplinary care. And don't forget, stroke recovery isn't just physical. There's a lot of emotional and cognitive adjustment, both for patients and their families. As nurses, we're there to support, educate, and advocate every step of the way.